Dr. Pelosi again. Thank you so much to be here. And everybody is excited to hear from you. And you have the words. Thank you so much.
All right. Well, thank you for having me. Thank you, everybody, for tuning in. And if you don't speak English, I'll speak slowly. And I wanted to talk today about vaginal laxity, because this is something that doesn't get addressed by many gynecologists. We have gynecologic issues that everybody knows about. We have pelvic organ prolapse, the traditional cystocele, rectocele, enterocele, all of the stuff that you find in residency training programs, all of the stuff that's addressed in urogynecology, and all of the stuff that you find in the classical textbooks and the conferences like ACOG and OGS, and all of the international societies that traditionally have taken care of prolapse problems. But prolapse is only one of the components of the symptomatology. It's the most obvious one. It's something that we can see with our eyes, and it's something that we can assess physically because it's an anatomical defect. So when a woman comes in and is examined and is found to have prolapse, you can tell her that something is broken, something is not right, and there are treatments that are traditional for that. But beneath the level of clinical problems, there are lifestyle problems beneath the surface. And these are not always apparent on the clinical examination. When somebody says that their sex life became bad after childbirth, when it used to be good, that's a lifestyle issue. You're not going to find it in a book. It's not the same as having a sexual pain problem. It's not the same as having a fertility problem, because it can't be identified by looking at it. It's a subjective symptom. It's because sex is not a one-person project most of the time. Sex is a tango. We have the man, we have the woman, and they get together, and it's a problem between this specific man and this specific woman, sometimes anatomical, the specific man anatomy problem, and the specific woman anatomy problem. And there are many things involved when there are two people. But you're not going to find that in a textbook, because typically medical care was to fix broken things, and the sex life was considered something that's not really a medical problem. It's sort of like you go to the gym to stay in shape. Being out of shape is not a medical problem until you have a medical condition with the blood pressure, with the sugar. So think of it along those lines, and you'll understand why doctors traditionally haven't given or paid much attention to vaginal laxity. Okay? And then, 20 years ago, Viagra came out. And for the very first time, there was a medicine to fix a problem with the tango for the guy. Fix that, and he can have sex again. And for reasons that aren't fair to women, Viagra got covered by medical doctors for various indications. You know, you could stretch the truth and say you're giving it for pulmonary hypertension. Believe me, the people that take Viagra don't have pulmonary hypertension. They just want to have better sex. And now something has come out for women. Now, curiously, what came out for women came out 20 years ago, 30 years ago, maybe even 100 years ago. It was the surgery to tighten the loose muscles of the vagina. But what happened was that people that used to tighten the muscles to try to fix pelvic prolapse problems, they would tighten these things in a very aggressive way, and patients had problems with that type of surgery. So when people put into the category of things not to do, they said, don't tighten those muscles. Because the people that used to tighten those muscles 100 years ago always had problems. But nobody ever asked the question and said, is there only one way to tighten the muscles? Are there ways to do this muscle tightening that doesn't hurt all the time? But nobody gave it much investigation because there were other operations to fix the rectoceles and the prolapse. And they just said, you know what? Let's not bother with that. Let's just fix the fascia. Let's just fix the bulging skin. Let's just do a regular prolapse operation and send the patient home. So that was the background to the surgical procedures that involve tightening the vaginal muscles. So what did the gynecologist do when the patient said, oh, I have a loose vagina and now my husband has Viagra and when we're doing this and it's not a good tango. So they said, well, you can go for pelvic floor muscle therapy and that will work to a degree, but sometimes it's not enough. And sometimes it works better in combination with surgery. But if everybody for the last 100 years has been telling you that tightening the muscles creates pain, and your teacher, your professor tells you it causes pain, your textbooks tell you it causes pain, and you don't have anybody telling you that it doesn't cause pain, you're not going to do that. Until David Matlock came around. And David Matlock had a way of tightening the muscles that didn't hurt. And maybe he was lucky. Maybe he was innovative and found a better way to do it. But he became the first person to make this a popular option. And he didn't have the problems of pain. And now he was able to give women something now that the men could get something. But the medical insurance didn't cover it. So if you have a medical practice in conventional gynecology, you offer services that typically are covered by medical insurance, and you don't really do a lot of cosmetic work or work that doesn't involve insurance. And you're very uncomfortable with talking to patients about money because you don't do it. Like if I told you that I want you to learn to go sword fighting and you want to fight a world expert, you feel uncomfortable because you're not trained in it, you have no background in it, and you just say, you know what, I feel more comfortable just not doing that. And you look for excuses and you say, even though that guy from California is getting good results, my professor said, don't do that. So if I have something that I don't do, I'm not going to talk about it to the patient as an option, and I'm going to give her the traditional options, which are back to the pelvic floor muscle therapy, which help, but they don't help enough sometimes. If you have very, very damaged muscles, imagine that you have, I guess, Brazilians love your soccer, your football. Let's say that the football star breaks his leg, okay? The doctor doesn't tell him to go do muscle exercises. He fixes the broken leg, and then he does the muscle exercises because he knows that when you do exercise on broken things, it doesn't work out very well. So that would be the equivalent. Okay, you have your woman, you have the guy with the Viagra, and the woman has like the equivalent of a broken leg for a vagina, and you're telling her to go exercise the leg. What do you think is going to happen? Well, the muscles might get stronger, but the function of this isn't going to improve very much. But once you have people on board doing and believing and seeing and having confidence in vaginal laxity operations, and there's a background because now there are years and years and years of people doing these operations, you can't ignore it and say that the patient who had good results doesn't exist because my professor, who heard from the other professor 100 years ago that that's not true, obviously there's miscommunication. So we have one group of people that are getting great results from doing these operations a certain way. And we have another group of people who have been taught with the traditional knowledge but it was based on a different style of doing work, that operation is no good because they're not talking to each other and seeing what each other is doing. They're just talking in different directions and saying, that's bad, that's good. It works for me. My professor said it doesn't work and it can't work. So now that we're in the age of information, of communication, like we can communicate with anybody we want. If we have their email address, we can call them up right now or email them and talk to them and say, what are you seeing? We can get immediate feedback and we can see what's working, what's being done exactly, and why it's working and who it might be good for. So that's the scope of vaginal laxity today. The challenge is making patients aware that these options exist. Because if they don't know that the option exists, they have bad sex life and they don't think they can do anything about it. And the most important thing is for the traditional gynecologist, urogynecologist, and pelvic floor therapist to understand one thing very clearly, okay? If a patient has a problem, they're gonna look for a solution. And if you don't provide the solution, they're gonna go to a non-expert because nobody else is listening to them. So if you don't provide the service, at least you can recommend them to look for somebody that specializes in the service, but somebody who has a background in pelvic floor work. Because if you don't have a background in pelvic floor work and you don't understand the pelvic floor, you're going to start offering procedures just to make money. So you're going to, like I always say, it's just like selling ice cream. Instead of having a specialty chef cooking special meals just for your special diet and specific needs, you have somebody selling ice cream. If you want it, you can eat it. You know, just have some ice cream. Here, I have a product, just buy it, and I'm done with you. And there's no follow-up, and a lot of these people get procedures that they don't need, they waste time, they waste money, and then they get depressed and they start to think that none of the new technologies work very well. When the real problem isn't that the technologies don't work well, it's that some people don't know when to use them, how to use them, how often to use them, and when not to use them. So if they just, we call it praying and spraying. We just throw the procedure out at anybody who wants it, you're never going to get great results because any procedure has to be done to the right person at the right time. It's just like anything else you do in the practice. You already know that. Don't do a hysterectomy for a bad pap smear. You don't do fibroid surgery for somebody that doesn't have symptoms. So you need to have a background in problems. And you have to remember that if you don't address the problem and you tell the patient there's nothing you can do because 100 years ago there was nothing that worked, that patient now is going to get on her phone, she's going to put in the name of her problem, and she's going to put in where she lives, and she's going to find the dermatologist, she's going to find the hairdresser, and they're going to get a treatment from somebody that knows nothing. But not only that, some of the people they find may be criminal, they may be so uninformed that they do damage, and they might create new problems that the person didn't have. So that's something that I have a problem with. And that's something that actually I saw happening with the American College of Obstetricians and Gynecologists about 3 years ago. They decided to have an expert panel on cosmetic gynecology. But the experts weren't experts in cosmetic gynecology. They had an expert in urogynecology, traditional, that had no background in cosmetic procedures or these newer operations. And then you had another one with the same background. So you had somebody that doesn't know anything about this talking to somebody else, and they decided that they should get rid of all of the language that patients use to find these procedures. So what does that do? Well, the woman who has a problem may not have a medical degree. In fact, most people don't have a medical degree. There's 7 billion people on the planet, and there's not 7 billion medical degrees out there. So only a small fraction of the population knows the medical terminology. And if the College of the United States that represents all of the gynecologists puts out a statement that says, we shouldn't use this language anymore, how are they going to find us? How are they going to find the technical language that only a small fraction of the population uses? Okay? If I wanted to sell ice cream and I listed the ingredients and I didn't use the word ice cream because the American College of Ice Cream decided that we shouldn't use non-scientific words, who's going to find the ice cream? Nobody. Who are they going to find? They're going to find the people that use the word ice cream, that use the word vaginal rejuvenation, and guess what? Guess who's number one? Plastic surgeons, dermatologists, emergency room doctors. Everybody except the American College of Obstetrician Gynecologists. So I understand that they understand that it's a vague term. But they are forgetting that that is the language of the patients they're trying to take care of. So it would be the same as if I said, you know what? I'm going to speak to my American patients in Portuguese. And they won't understand a thing I'm saying, but the American College of OBGYN decided that we're not going to speak their language anymore. It's no different than that. So don't you think that if you were going to make services for people, you should speak their language? Yes. Yes. If you think no, just raise your hand. But if you're doing a clinical study, that's different. If you're doing a clinical study, you want to understand exactly what you're studying, and you want to know exactly what you're doing, and you want to make sure that the word that you're using to explain what you're analyzing is very specific. So I agree that we shouldn't use vague terminology to do studies on specific things. But that's not the real world of the patient. When the patient sits in the office, it's our job to educate the patient. But it's also our job to get the patient into the office in the first place. So if we're going to succeed in helping women, we have to be able to get to the women. Because if you can't get to them, you can't do anything. And they're going to be sitting in some non-specialist office having all sorts of problems. Next point. Talking to the patients about vaginal laxity. It's not easy. You see, vaginal laxity isn't just putting the fingers in the vagina for the doctor and doing this and saying, oh, the vagina is wide. It's loose. Because remember, it's a tango, okay? If I have a pair of shoes that are too big, okay, the problem might not be the shoe, it might be the foot. Maybe I have the wrong size shoe. A woman can't change her vagina, but that doesn't mean that that vagina is the wrong size for every woman, because every relationship is an individual. It's a woman and it's a guy. So I can't just examine 100 women and say, okay, when they meet this centimeter of width at the hiatus, that's laxity. Because if I do that, I'm ignoring the fact that sex is a tango. And why would I want to ignore that? So that's something to take into consideration when you tell the woman, you know, I can tell her she has a pelvic floor issue, but I can't really tell her she has a loose vagina. But I have to ask her if sex is okay. And I think that's the best way and the most non-judgmental way to go about asking about it, is say, how's your sex life? They're going to say it's okay, and they're going to say it's not okay. And then you have opened the conversation. And you can tell them, well, what is it about sex that's not okay? And how long has it not been okay? And is it getting worse, or has it been not okay since the specific day and it stayed the same for many years? And once you open that window, now you're into a real discussion about vaginal laxity. and you have to get comfortable speaking about it. It's a lifestyle issue, but it's probably the problem that brought her into the office. And I can almost guarantee you that most women with laxity have pelvic floor issues that fall into traditional diagnoses and have traditional findings. But they're usually on the milder end of the spectrum. So in a lot of situations, you know, I can tell you that almost every woman that has a kid has a little bit of a cystocele and a little bit of a rectocele. Okay? And if I ask them, how's sex? And they say there's no problem, I can tell them, you know, listen, you know, if sex is no problem and you want to keep yourself in shape, then go for pelvic floor muscle exercises, because the muscle tone there is preserving the status quo. But if she says, no, I have some problems with sex, you can try the muscle therapy first. But if the muscles separate and the therapy didn't strengthen the muscles in a way that allowed this to happen, okay, then you have a candidate for a treatment for vaginal laxity. And that treatment is surgical. And if you're relying on 100-year-old information, on 100-year-old operations as the basis for your discussion, you're really not doing your patient a service, telling her that you know, nobody does these procedures. If you know that these procedures are effective in certain people's hands with certain techniques. Now, the techniques aren't difficult. They're not much different than traditional anterior and posterior repairs, but they are different. And if you just do a traditional posterior repair, you can expect not to get a good result. Because if it had worked for the last 100 years, doing it the traditional way, this whole specialty wouldn't exist. The regular procedure takes care of it. There's no reason to change that. So the fact that it exists and it thrives and it takes off and it becomes more popular and that women seek out these procedures, it's because they work. Because if they didn't work, I wouldn't be in business. And I have patients that come from very, very skilled, very renowned, very experienced urogynecologic surgeons. So I know that those procedures are being done very well in the traditional way. And that just adds further proof to the fact that they're completely different operations. So yeah, you can restore a pelvic floor with traditional operations, but you're never going to tighten the vagina, because that's not what they're designed to do. Because those steps of the procedure were removed 100 years ago, because those steps were done in a different way than the way we do them today. And today has a track record now going back about 20 years. So that's your overview on vaginal laxity. What I think about the language. So I've said my piece. If you have questions, you know, you can raise your hand and I can unmute you, or Laira can unmute you and we can discuss things.
Hello, Marco. I have a question too. Usually I start. Do you ask about the sex life to all your patients?
Yes. Now,
it's amazing. It's amazing.
You have to. Now, take a look at what's happened to gynecologic practice, okay? And this is all coming from gynecologists who have nothing better to do, in my opinion, okay? A gynecologist does a study to see if women should come every year for a pap smear, and they said, no, don't come to my office. For many women, pap smear equals gynecology visit. And when you tell them don't come for a pap smear, that's like telling them stay home, okay? Just like coronavirus, don't come. And then, you know, the other researcher says, no, wait, I have a better idea. If the HPV test is negative, we're not going to see them for 5 years. That means that a 40-year-old woman, okay, who lives with a lifespan of 80 is only going to see the gynecologist 8 times before she dies. But it gets even worse, because at 65, they tell them don't go for pap smears anymore. So you're only going to see them 5 times before they die. How can you run a practice like that? How can you deliver healthcare seeing somebody 5 times for the rest of their life from middle age? That's absurd. Okay? So that's gynecologists cannibalizing their own specialty. So what are you going to do if you don't bring them in for a pap smear? Okay? Now, they tell you that pelvic exam is no good. Who says no good? People that don't know how to do a pelvic exam, their pelvic exam is no good. Because they don't know. So if you base your practice patterns on idiotic epidemiology, you might as well go sell ice cream because you're going to be out of business. You're going to offer women absolutely nothing. So what are you going to offer them? You're going to offer them what you can offer them if you have solid knowledge of the pelvic floor, anatomy, physiology, all that stuff. You're going to give them a great lifestyle. And you're going to use all of your skills to fix everything that's broken around that lifestyle in the pelvis. So to me, I have to ask. Otherwise, what's my care going to be different from a medical assistant who's just doing a pap smear with their eyes closed? It's like, come back in 5 years. What good is that?
I totally agree. I think we need to take care of the patient and part of our patients. So I always ask my patients about their sex life. And do you recommend physiotherapist before your surgery?
Well, it depends on what's broken. You know, if I'm fixing a pelvic floor issue and the muscles are in good shape, they probably don't need anything in the beginning. They probably need some post-operative physical therapy. But if the muscles are weak, absolutely. You absolutely can benefit from combining it. You'll have better surgery, you'll have better recovery, and you'll have better results.
So you can find good results with your physiotherapist?
Absolutely. It's not one or the other. It's a team project. You know, look at the way that the orthopedic surgeons work on their patients. Okay? Physical therapy is part of the procedure.
Okay, thank you.
You're welcome.
Dr. Elio, do you have a question?
Yep.
Yeah?
Yep. Marco.
Yes.
It's a pleasure to hear from you for talking about laxity of vagina. One question. Well, you still perform the pelvic examination, or just look around the ultrasound and don't put your finger in the vagina and you can feel what's going on? This is the first question. Second, do you believe that there are a great place to the use of laser on case where you have no broken fascia or no big muscle disaster? Do you think that you have a big place in the future for the use of laser in those cases of vagina laxity?
All right. So the first question was ultrasound versus pelvic exam. You can't take a look at something without feeling it and find the problem. I have plenty of patients that have pelvic pain, negative ultrasound, negative laparoscopy. So you know them too. You see these patients too. So the pelvic exam there is critical.
Yeah.
And you can also have abnormal ultrasound and pelvic exam that shows something completely different that they didn't expect and doesn't make any sense. So if I have a pelvic exam and I see a fibroid, but all the pelvic pain is on the nexa, hysterectomy would be the wrong operation. And you can't tell that without doing the pelvic exam. So I never dismiss the pelvic exam, but you have to really do the pelvic exam. It has to be a good exam, a thorough exam. It can't be just a quick 1, 2, 3. If you're going to do a quick 1, 2, 3, don't do that. That's not a pelvic exam. That's a fake pelvic exam. That's fake news. You don't want to do that. You want to do a real exam. A real exam, just like the old timers used to. Those guys could examine you with no technology and tell you 100 different things about your body. Now, your second question about the lasers. Well, lasers do certain things. So you have to say, what is it about this woman's problem that I think I could improve with a laser if I need to improve anything at all? So if you're talking about vaginal atrophy being part of the problem, that's certainly a tool for vaginal atrophy, and it works very well. But if you're using the laser with the hope of tightening the vagina, it doesn't work very well because it doesn't tighten the structures that are loose. It's just tightening the skin. And it doesn't do a very good job at that either. It does a very good job of improving the blood flow and increasing the secretions. So that's what it's good for. So if you're trying to use a laser to cure vaginal laxity, I think you're using it for the wrong reason.
Yeah, I completely agree with you. Yeah. Yeah.
We have another question. Marwan?
Yes.
Dr. Elliot, do you need Marwan?
Yeah, one more.
Okay.
Just one more. Yeah.
Sure.
Yeah. Marco,
Yeah.
when you have a patient that comes to you after one operation to restore a reticle cell or another kind of vaginal operation to restore the anatomy, but she still has the problem. She feels she feels very large. Well, what do you do in this kind of patient? Do you recommend another surgery, or you recommend physiotherapy, or what do you do?
Well, first thing you have to do is examine the patient and see the status of the anatomy. If the anatomy is perfect and the muscles are in good condition and they're in the right position, then she needs physical therapy exclusively because that's the only thing left to fix.
Yeah.
If the anatomy shows that the muscles are separated, well, that's something that needs to be fixed if she's feeling large. Now, some women just need to be educated because some women don't understand that there is a limit to the vaginal tightening section of the vagina. Okay, the levator muscles don't come together by the cervix. They only come together at the mid-vagina. So when I examine these people and they say, I feel loose, all the way inside, as long as they don't have an enteroceal, I tell them that that's normal. They just didn't understand that because they weren't counseled about it and they were told to expect something different. So their expectation was out of alignment. That's my
Thank you, Marco.
You're welcome.
Hello, Adriana. Do you have a question, Adriana Smith? You can open your microphone. Hey, Sherry?
Yes, I don't know. Oh, okay, I'm sorry, I didn't realize it was open, okay. So what we do in our space is, because so many women, they don't know what they don't know and they don't know what they need. And we often recommend that they explore the physical therapy first. They don't know if they're ready for surgery or not. And by suggesting that, it enables them to understand those sensations that occur down there. Often they don't even know what a PC muscle contraction is. And so by suggesting they try the physiopath first. We like it both pre and post surgery. If they try it first, it helps them understand what those sensations are, what a contraction feels like, whether or not they can even have a contraction, because some can't have any contraction at all, whether it's from levator damage or it's so lax that they can't even contract that muscle. If they do it before, and because we recommend maintenance for life is what we're all about. It's not over when surgery is done. You're doing this for the rest of your life. Brushing your teeth, contracting that pelvic floor muscle. If they do the PT stuff first and then they have surgery and then they go back to the PT afterwards to get that balance back, it's the best. It's just the best. And we find that it typically takes women that don't want surgery about 2 years of seeing a physio before they decide that they actually do want surgery. They cannot deal anymore with just trying the maintenance route. It's not going to work for them. They're ready to take that step to the next level and have the surgical procedures that they really do need. Like you're saying, Marco, damage is damage. And if you've got certain kinds of damage, you can contract those muscles until your face falls off, and it's not going to do any good because of the structural damage that's going on down there. The laxity is so massive that you just can't get it back to where it needs to be. So we like it on both ends. I just thought I'd throw that in there for seeds.
Sure. But you have to make sure that the physical therapist is a specialist in the pelvic floor.
Exactly. Yes.
Yes, we need to be specialized on that. It's not all physiotherapists that can work with pelvic floor muscles. And most of women, 30% of women cannot contract their pelvic floor muscles. They don't need any tool for that. It's because it's a muscle inside of us, and we don't have contact with these muscles. So women that don't have any problem in their pelvic floor maybe cannot contract their pelvic floor muscles. Adriana, are you try open your microphone again? Are you there? So
sorry, people. I'm a little bit busy here. I'm not able to talk actually. I don't know if you understood my questions.
Ask it again.
Okay, no, because it's right here.
I'm sorry, I was asking about new technologies for Dr. Pelosi, lasers and radio frequency and filling agents. If he uses this kind of technology isolated or in combination, any kind of this new measures that we have for vaginal laxity?
No, those procedures are more for improving blood flow. They're not really for laxity. So we use them, but they're not part of laxity.
Yes, I agree with you. I think there is a lot of misunderstanding with those new technologies. They are very good for atrophy, as you said, but for laxity, unfortunately, I couldn't see so good response. And I would like to know from you if you have the same sensation.
Well, I don't think that people should be just buying machines and offering services. They really need to learn the problems. They need to learn the technologies. And they need to know what the technologies are designed for and what they're not designed for. But what happens a lot of times is you have a very aggressive salesperson at a meeting, sells you a machine and tells you it treats everything. Just buy it and you'll be making $1 million every day. And
yes, sure.
You believe it. And since there's not too many specialists around to tell you the real story, you start doing these things and you start seeing a lot of unhappy people and you start to get worried that maybe you're doing something wrong. So, you know, you're in the right space by following doctors that specialize in these procedures. But for laxity per se, we don't use these technologies.
Perfect. Thank you.
You're welcome.
Thank you, Adriana. Somebody else? Dr. João, Dr. Ricardo, Tacílio. You can speak.
Yep.
João, you can unmute yourself. Anybody else?
You.
Again, please?
Yeah. Marco,
Yes.
I know that my question is not about laxity. It's about a new cosmetic GIN surgery. What is your opinion about?
Cosmetic?
Yeah.
Well, it's no different than doing
Labioplasty and blah, 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 blah.
a labioplasty is no different than a rhinoplasty. No different than breast augmentation. No different than any other procedure to change the normal anatomy. So if you want to change your anatomy to look a different way, and the doctor knows a safe way to do the operation, that's patients' right to do whatever they want with their body.
It's okay.
And this kind of surgery can make an issue in their sexual life, and they can have less pleasure or pain, or the clitoris is not have so pleasure or sensitivity.
Well, if you do it wrong, you can do anything like that. You can kill people. But if you do it right, no, it's very safe procedures. So most of the people that have a bad story usually had the procedure done in a poor way. So if I drive my car into a tree, there's nothing wrong with the car. There's nothing wrong with the tree. I just used the car in the wrong way in relation to the tree. So if you do things properly,
It's funny.
criticize the operation if you did it wrong. You just criticize the lack of training.
That's funny.
Somebody else? Dr. Tacilio, you want to say something?
Yes, yes. So, Marco, your experience with intense focused ultrasound and radio frequency for mild laxity, as I understood, you never indicate those procedures for a woman that you were not comfortable suggesting a perineoplasty or a surgical repair of the laxity. Would you indicate, I understood that you said that the laser doesn't go deep enough, but
No.
intense focus ultrasound or radio frequency to try and tighten the vagina non-surgically?
Well, first I'll tell you that the high-intensity focused ultrasound, HIFU, is not a technology that's available in the United States, so I have no experience with it. But,
really?
Yeah, really. Radio frequency, you have to counsel the patient that it's probably not going to work because it's not going to be intense enough. Now, there's different kinds of radio frequency. There are the surgical radio frequencies, which go deeper, which do have a little bit of the effect on the fascia. But right now, with the technologies the way they stand, I haven't seen too much that impresses me. Except I saw Dr. Jorge Gaviria is using a transanal and transvaginal combined treatment with erbium laser, sub-ablative. And they're improving rectoceles. And from what they're telling me, this is very early data, they're getting results that are lasting about a year. So that might be an indication for treatment in advance of surgery if it's not too bad of a symptom, because if you can improve a rectocele, as far as the bulging symptom, non-surgically, now you can do the old diabetic lady, you can do the one with the triple bypass, you can go to the intensive care unit and you can fix all these people that normally you would never allow into an OR, and your other option would be a colpoclysis or something that really doesn't address the problem.
Yeah.
Yeah, so those are my thoughts on that.
Yeah, and it's good that in a way that the radio frequency, as you said, wouldn't have a very good result, because otherwise even non-medical specialties would be using it for that purpose.
Yes.
Okay.
Dr. João, do you want to say something?
Yes, yes. I was thinking about. Thank you for your nice talk. And you in the beginning of your talk, you are talking about about men and women compatibility. Okay, and sometimes, like I told you before this meeting, and in the launch of this meeting, I have told you that I have no experience in this field. Where you have talked to me something about this, but the question I want to ask you is about the sensory, and nowadays I'm studying about something about the sensory and the innervation of the pelvis, and sometimes I'm trying to beginning to see most of the sexual disturbances and sexual problems can be about sexual arousal and all that problems that can be a sensory and a motory innervation. Do you think with your experience in laser that you can ameliorate that kind of disturbs?
Well, from what you're saying and from procedures I didn't discuss, there are some newer laser procedures with cold lasers. I don't know if you've heard of SOLA therapy, S-O-A. Well, what the whole premise of this is called photobiomodulation. So what they're saying is that they are able to affect the nervous response in the pelvis in a positive way, and control the response to inflammation with laser therapies to get pelvic floor myalgia treated at the muscle level by affecting the nerves to the muscles with a cold laser. So just look it up, SOLA therapy, S-O-L-A. And if you follow me, I've done podcasts on it recently. You can go to drmarcopelosi.com and click on the social media page, and you'll find the podcast on SOLA therapy. Very interesting stuff. It just came out.
Okay, thank you.
Thank you, João. Dr. Carlos, do you have some question? Carlos Del Roy?
No,
Okay. Dr. Sergio Camargo, do you want to say something?
No, not for today. I'm satisfied. Thank you.
Okay, thank you. Dr. Ricardo, say something, please. Say hello.
Hi, Marco.
Hey,
hello.
How is the push? How is the push?
A pleasure to see you here with
You too, my friend.
these friends. I have no question.
It's nice to see you.
You are a lucky man. You have no question.
No question.
All right.
So, if everybody else is satisfied, I am. Thank you so much.
I want to say something. Can I say something?
Of course.
Yes. Well, we all know that Marco has been an advocate, I would say, of the ethics cosmetic gynecology, and this is very important for this subspecialty to advance. I would like to hear from you, Marco. How do you see the strong opposition that we have from the societies and even our colleagues when we approach this area? Because I am pretty convinced that when we combine the functional restoration of the genitalia with the aesthetic, we're bringing a lot of benefits to the patient. But still, this is like a taboo. Could you share with us your thoughts on this subject?
Yes, yes, yes. I don't think it's going to be a battle that's going to be won between the opponent today and the pro today. What's going to happen is that the opposition is going to die off because the patients that are seeking the procedures are finding the doctors that are providing the procedures in the space of the early adopter. And as new doctors come into training and they want to start a practice, they're younger, they're more open-minded, and they're going to gravitate towards these newer procedures. So I think that the opposition isn't going to be beaten off head to head. I think they're just going to die off because they're going to become irrelevant in this space. And people are going to start to see the better results. And what you're going to have over the social media is patients talking about their better results. And the more better results that are out there, they're hard to ignore. So the colleges are going to lose credibility and they're going to lose power because of this.
And especially, I think the big thing is to combine the functional restoration with the aesthetic restoration. I think that's crucial in my opinion.
Oh, absolutely. Just think like the orthopedic does. It's a multi-person, it's a team approach. It's not just, I do my surgery and she's fixed. No, I do my surgery and we're just starting with the other phase of the treatment.
Yeah. Okay.
Following Dr. Otacílio's question, how long do your patients wait to look for help? Because cosmetic gynecology, how long are they surfing before to find some help?
Well, I was so surprised when I have had a lot of resistance to get into this field, and I owe this the slackening of this resistance to Marco too, because he said, Otacílio, you have to, this is the future, you have to do this. And I was always, maybe because I'm a surgeon, I always thought this was something that, nah, it doesn't smell good, that kind of thing. So when I started asking my patients about things that I never asked, I mean, they have this, for instance, they have this huge labia, and I have done their C-sections, I have taken out their uterus, I have done a sling, and they're my patients for like 20 years. And I asked that like after 20 years, and then she comes to me and says, Dr. Otacílio, this has bothered me all my life. And I go, why didn't you tell me? Oh, I am ashamed. I didn't think I had to tell you. I think I had to tell a plastic surgeon. So I was really, this was an eye-opener when I started asking the patients. The problem, some of the taboo is because the doctors, they don't ask. If you start asking the patients ethically and without offending the patients, you know, you just ask, and this is where the functional restoration comes, because you can, for instance, say, well, we have this new technology in the office, so we are doing the laser for the restoration of your atrophy, and the laser can also do this for your labia, do this for, you know, and the patients, believe me, I wouldn't say all of them, but the majority of the patients will be interested. Of course, there will be patients that will say, no, doctor, this doesn't bother me. My husband never said anything. End of story. End of story. But in my experience, the majority of patients will say, "Doctor, this has bothered me for all my life, and now that you asked, I want to do something about it."
Yeah.
Dr. Pelosi, and your patients, how long do they wait to ask for help?
Oh, I asked them first.
Okay.
I said, what can I do for you?
Perfect, thank you.
Yes.
And if you don't do anything, the worst part of it, in the waiting room, they're going to go in the internet, in the social media, and they're going to find somebody to do the procedure, like your neighbor, for instance.
So, is everybody okay? Someone have any more question?
Marco,
Yes,
say hello for your papi.
I will.
I
will,
wait him in
definitely.
Brazil to drive the GT2.
All right, beautiful.
Okay?
Okay.
Not now, please.
Good to see you.
You too.
Marco, really, thank you so much for this conversation.
What's that?
I'm learning a lot this in this time, in COVID time, and it's very good to hear from you that laser is not for vaginal laxity. It's amazing because I know some professionals are using this, and I totally agree with you. And you changed my point of view after my conference there in Las Vegas. And now I can see cosmetic gynecology in another point of view. And I can understand more how this can help the patients. And thank you so much. You changed my mind.
Well, thank you for having me. It was a pleasure. And thank you, everybody, for coming on board for the conference. Take care.
Marco,
Thank
say
you.
my regards to your father.
I will.
Okay? Big hug to him. And to you too.
All right. Bye-bye.
Okay.
Thank
See
you
you,
so
babe.
much, guys.
My
Bye-bye.
idol.
Bye-bye.
Bye-bye. Thank you.
Bye.